Hello everyone, welcome back to our mini lecture series on high-yield diagnoses and what level of care to assign when admitting them. My commitment, as ever, is to get this information to you in 5 minutes or less. February is COPD Exacerbation Month. We'll be talking about the findings and treatment modalities that will meet criteria for admission and provide some key differences between the observation and inpatient levels of care. Here are our observation and inpatient criteria. Really, I just like to pull this slide up as a reminder that if there's ever any doubt, you can always refer to your badge buddies at the time of admission. Here, I've written out the observation criteria for COPD exacerbation. I find that specifically for COPD, because of the multiple avenues by which we can select level of care, the flowcharts we'll see later make it a little easier to digest. And same with the inpatient criteria. Most notably, if the patient is intubated or on BiPAP at time of admission, it will always be an inpatient admission. Another reminder about COPD, if you're doing more than 3 nebulizer treatments in the ED, not only should you be strongly considering admission anyway, but it's highly likely that the patient will meet criteria for inpatient. We're not going to go into the nitty-gritty about this point in today's talk, but anything over 3 treatments is pretty much always inpatient. So the flowchart is a little easier to look at than the written steps. You suspect COPD exacerbation, so you start your breathing treatments. This is probably the most important point in the entire lecture. In order to even admit the patient, you need to have 2 breathing treatments administered, even though this frequently amounts to us ordering a second treatment and then calling for admission. So ensure that you start your treatment early on in the patient's course. After breathing treatments, you can admit based on a combination of factors, subjective and objective alike. If the patient is satting around 90 to 91% on room air, or on their baseline O2 at 90 to 91%, if they're having increased work of breathing, if they're not able to speak in full sentences, or if they can't lie flat, then at that time you can admit them for observation. Again, remember intubated or BiPAP pretty much bypasses this whole chart and will be inpatient. After you do your usual 2 breathing treatments, if the patient is truly hypoxic, at less than 89% on room air or on their baseline home oxygen, having increased work of breathing, if they're altered, or if they're showing signs of sepsis, and this specifically amounts to pneumonia, WBCs over 12, bandemia greater than 10%, or fever, then the patient can be admitted as inpatient. I know it's kind of a mouthful, which is why the flowchart makes it a little easier to see. And that's all. At the time of this lecture's creation, the emergency department is moving away from placing admit orders, which otherwise would assign level of care, so this will probably be the last time you'll hear my voice on one of these for the foreseeable future, but I truly appreciate your attention to ensure that we're doing the right thing for our patients in the Central Valley Network. Thank you.